What? Okay, when you want me to start talking? Good afternoon, everyone, and thanks for joining us for today's Prescription for Cost Control webinar. This webinar is part of Kelsey Care's Bending the Cost Curve series, so thanks for joining us. We're very excited to share with you the results of our RxQI program. I'd like to get the webinar started and introduce you today to today's speaker, Dr. Pat Carter. Dr. Carter is the Chief of Family Medicine and Director of Care Coordination and Quality Improvement for Kelsey-Seybold Clinic and for our Kelsey Care Health Plan. Dr. Carter has practiced medicine at Kelsey-Seybold Clinic since 1994. His specialties include family medicine and geriatrics. He is board certified by the American Board of Family Medicine, and he holds the Certificate of Added Qualifications in Geriatric Medicine, which is granted by the American Board of Family Medicine. He's also certified as a physician executive by the American College of Physician Executives. He has been recognized with National Certification for Excellence in Caring for Diabetic Patients. That's awarded by the National Committee for Quality Assurance, NCQA. Just one item before we start, there will be an opportunity to offer questions and get answers. Instructions on how to ask a question are on the left side of your screen, and we'll have a Q&A session immediately following the presentation. Thank you, and here's Dr. Carter.
Thanks, Ann, and welcome everybody. It's good to have you all online to talk about trying to control costs. I think I'm going to start off with some shocking news here. I think somewhere in the Affordable Care Act there's a line that says any talk about health care now going forward has to start with this first line, which is that health care costs too much and it's only getting worse. Big part of that is pharmaceutical costs, not the majority by any means, but still a significant part of health care costs are pharmaceutical costs, which I don't think is probably surprising to anyone. The final line on this slide is something probably everybody knows, that the cost of generic drugs is significantly less than the brand name equivalent. One thing I'm not sure everybody is aware of, and frankly I think a lot of doctors don't realize this, is how much of a difference in cost there is between typical brand name drugs and the generic drugs that could be used to substitute for them. So what I'm going to start off with is showing you exactly what some of those differences are, and this is not, it's kind of a random selection of 4 very commonly used brand name drugs, with drugs that are generic and that are basically therapeutically equivalent to them. The first one is Nexium. That's a drug that's used for acid reflux. The generic name for that is esomeprazole. About $6.50 per tablet. A generic drug, pantoprazole, which is actually the generic form of Protonix, you can get it for 85 cents. Zesteretic is a commonly used antihypertensive, a blood pressure medicine. It's a combination of 2 different drugs. The generic name for it is lisinopril hydrochlorothiazide, so this is actually chemically the same. Difference in price from about $1.60 down to 24 cents. Benicar is another commonly used antihypertensive. It's called an ARB, or an angiotensin receptor blocker. $4 a day for Benicar. Another ARB that's generic losartan works about the same. Most doctors would consider it to be equivalent. Is about $1.11 per tablet. Final one is the Actonel. This is a drug called a bisphosphonate, and these are used for to prevent and to treat osteoporosis, or weakening of the bones. This is not a daily medicine. It's actually once a week, so the price of the tablet is maybe not quite as shocking as it looks, but $30 a week for 1 Actonel tablet. The generic alendronate, which is the generic form of Fosamax, again therapeutically equivalent, is about $4 a tablet. So as you can see, differences of 4 to 8 times the cost of a generic versus a brand name is not unusual. And really the message here is that it's definitely worthwhile to get patients to switch if it's medically reasonable. And that's the reason for what we call our RxQI program, and that's largely what I'm going to talk to you about today. So one big issue with controlling drug costs is actually getting the doctors who write the orders for the drugs, who write the prescriptions, to care about cost, to care about cost at all. And one thing we think we do very well at Kelsey-Seybold is getting doctors to buy into providing cost-effective care. And so a question you might ask is, well, why should Kelsey-Seybold care if other doctors aren't particularly interested in this? And it goes back a long way, actually. We've been practicing evidence-based, cost-effective medicine really since the mid-'80s, and the thing that sort of stimulated us to go that direction was the fact that we started taking capitated contracts back then. I'm sure most of you are aware of what capitation is. It's where we get a certain amount per member per month, and we're responsible for all the professional fees for that patient. Right now, about 40% of our patients come to us through capitated contracts. And even though capitation is less than half of our practice, in many ways it really is the tail that wags the dog when it comes to what our philosophy of care is. So basically, whenever you've got a multi-specialty group practice that takes capitation, even if the majority of their patients don't come to them through capitated contracts, it really becomes extremely important for that group to do everything they can to control total medical cost. And we also have a strong incentive to achieve high quality measures and high patient satisfaction. And that is really, the examples I usually give about that is other multi-specialty group practices that take capitation, such as Kaiser Permanente and Scott and White. One thing about those groups, and same thing with Kelsey-Seybold, is we have a very recognizable brand name. We're very well known in our community, and it's very important for us to maintain our reputation as providing high quality care and achieving high patient satisfaction. One thing we believe strongly is that physicians are in the best position to influence cost and quality of care. And about most folks will say about 85% plus of stuff that health plans pay for have to have a doctor's order in there somewhere. So it's very important, if you can get the doctors on your side and try to think about cost-effective prescribing and things like that, that is a very, very powerful method of controlling costs. Unfortunately, it's also typically very difficult. So getting doctors who are in solo practice or small group practices to pay attention to these things from health plans or pharmacy benefits managers often is a pretty tough thing to do. But I will say one of the nice things about multi-specialty group practice is that our doctors are used to working as a team, and they do understand when they join us that we emphasize cost-effective, evidence-based care, so they're kind of used to hearing this sort of stuff from us. The result of that is that actually for us at Kelsey-Seybold, getting the doctor buy-in part is actually fairly easy. Most of our doctors are perfectly happy to switch patients from a high-cost brand-name drug to a lower-cost, therapeutically equivalent generic. The problem is making it easy for them to do so, and that's a lot of what the work was that we put into making the RxQI program successful. So it turns out that the logistics of switching these patients is not particularly easy. So even though in general the doctors said they'd be happy to switch patients from brand name to generic, it turns out, as you might expect, those doctors and their nurses already had full-time jobs, and they were not going to be able to find time to dig through all their patients and find the ones who are on the drugs in question, much less find the time to call them all up and convince them to switch. So we thought unless you could figure out a way to make this easy for them, it really wasn't likely to happen. So that's why we developed the RxQI program. And the idea in a nutshell is to identify patients who would benefit from switching from a brand name to a generic, basically present the list of those patients to the doctor who's prescribing those medicines, who would then be able to say yes or no to a switch. Then we would also do the legwork to inform the patients, get them their consent, and actually make the switch. So we took most of the busy work out of the doctors and the nurses' hands. And the first issue in this type of program is figuring out, who is on the drug. Now we do have electronic medical record, which is very nice, and it will certainly record accurately any drug, for instance, that I prescribe to one of my patients. But there's the problem with that is that a lot of patients will switch drugs, or they'll stop drugs, or they'll go to the emergency room and get put on different drugs. And unless we have all that stuff up to date, sometimes our medication lists are not quite as accurate as we'd like. So the best way to find out who's on a drug is actually to get the pharmacy claims data, find out what drug has been filled for that patient. And as you're probably aware, most doctors do not have access to that kind of stuff. Actually, in our case, we're not capitated for the pharmacy costs, so this typically wasn't information that would be sent to us as part of our capitated contracts. But we're very fortunate to have a very tight and unique relationship between our medical group and our two of our health plans. One is Kelsey Care powered by Cigna, and the other is our Medicare Advantage plan, which is Kelsey Care Advantage. And the folks who run those health plans definitely saw the benefit of giving us this data, and were willing to give us claims data in an expedient fashion. So that was the first step on the road, was getting that claims data. So anyway, the claims data is used to identify which patients are on this drug and who the prescribing physician was for the drug in question. The next step was to get the patient information to the doctor in an easy-to-use format. So just give me a list of patients probably still would take too much time for me to search through the records and look them up and all that kind of stuff. So what we did was we made it very automated. Doctors are notified monthly, so every month I get an email basically saying it's time to check my personal prescribing profile. And on that, which I'll show you in a minute, there's a list of my patients receiving drugs for which receiving brand name drugs for which there's a therapeutically equivalent but less expensive alternative. And all I have to do is select which patients I think might reasonably be switched. So as you can imagine, this involved a lot of work developing a user-friendly computer interface for the doctors. And again, I'm going to show you how that looks in a few minutes. Another whole lot of work went into what happens after I say, yes, it's okay to talk to this patient about switching. Then what that is we have a very fine, dedicated pharmacy staff that are dedicated to medical management programs like this. So they're not the pharmacists working in a retail pharmacy who are equally, if not more busy than the doctors and the nurses in the nurses' station. So these folks are dedicated to doing stuff like this, calling patients, talking about their drugs. So our pharmacy staff then contacts the patients to discuss switching to a lower cost medication. And one big thing that really helps them is, one thing they can say is, hey, your doctor's already approved this. So if you're interested in switching, it's okay, with Dr. Carter or whoever your doctor is. And another great thing is that the pharmacy staff has access to the patient's records. So in our electronic medical record, they can pull up my notes and they can check for any contraindications to switching, and which makes it actually a lot easier for me to say, yes, go ahead and talk to these folks, because I know that they are going to look for things like, have they had a bad reaction to this generic medicine? Do they have any side effects? Have we tried that generic before and it didn't work? So they can easily see if the drug we want to switch somebody to has been prescribed before, and if so, why was it stopped? So that, again, is a very essential part of making this whole thing work. And then if the patient agrees, it's very easy for our pharmacist to order the new medication in the electronic medical record and send an e-prescription to the pharmacy. And again, the EMR, the electronic medical record, makes it very easy to do this with just a few mouse clicks. At that time, the physician is notified of the switch, and the patient's advised to follow up with the doctor to evaluate the effectiveness or side effects of the new drug, the generic drug. So that's an overall view of how it works. Now I'm going to show you a few specific things about it. And this is what I see when I get my email saying, Dr. Carr, it's time to check your personal prescribing profile. What I do is I log into a little website that we've set up, and this is what it looks like. This is actually not my personal site, but mine looks like this. So as you can see, there are 6 classes of drugs. I think that's all the classes we deal with. I may be wrong, but I will see, okay, ARBs, which is that angiotensin receptor blocker, hypertensive medicine. I see, well, there are 2 of my patients who are two of my Kelsey-Care patients are on those medications. There's 8 of them on the bisphosphonates. Those are the bone loss medicines. One is on a brand name nasal steroid that's used for allergies. One is on the PPI, which is stuff like Nexium for acid reflux. One's on a brand name SSRI, which is an antidepressant medicine, and one is on a statin medicine, which is an anti-cholesterol drug. So what I do, I say, okay, let me look at my bisphosphonate patient. So what I'll do is I'll click on the bisphosphonate name, and it'll show that, lo and behold, this doctor has 8 patients on Boniva, which is a brand name bisphosphonate. It's like the Actonel, very similar. So and I say, okay, well, which patients are those? So I click on the Boniva, and then there's my list of patients. So the names are blurred out, but it gives the patient name, the record number, when they had their medication filled, and then next to that it says request pharmacy follow-up. I can say yes or no. As you can see in the verbiage above there, if you can read it, it says the pharmacist will be responsible for instituting any changes in the patient's medications that are approved by the physicians. All recommendations approved will be shared with the member, and all prescription changes will be called to the member's network pharmacy by the pharmacist. So part of the deal here is that the pharmacist will look at the record, talk to the patient, make sure the patient's okay with it, make sure there are no contraindications, and then go ahead and make the switch if everything looks good. So in my case, and I think most of our doctors' cases, unless I see a patient on there that I know darn well should not be switched for some reason, I just click yes to everything. And then I can go back to doing my day job, which is being a doctor. So that's kind of what makes it work for us. So what have been the results? Well, first thing I want to do is actually talk a little bit, actually have some actual patient examples of the amount of savings we're talking about for individual patients. This first patient is someone who is had osteoporosis, obviously, was on Actonel. It's that once-a-week drug I mentioned, $30 per pill. We switched her to the generic alendronate. Cost savings per year, $1,200, almost $1,300. That includes the plan and the patient cost. And you'll see as we go on, often one medicine switch, very commonly, it pretty much averages out to over $1,000 per year. So you're talking real money here. Here's another example. This patient was on 2 drugs that could be switched. One was diavan hydrochlorothiazide, which is a brand name ARB, high blood pressure medicine, at $4 plus per tablet. Got switched to lisinopril hydrochlorothiazide, a generic, which is the therapeutic equivalent, down to about 25 cents a tablet. $1,400 a year for that one medication switch. Lexapro is one of the SSRIs, an antidepressant. Got switched to the generic escitalopram. Not quite as much, but still significant savings of over $200 for the year. So the total savings for this one patient, patient plus health plan, was over $1,600. Next example, this is someone who's on the Nexium. This is the new purple pill for people with heartburn and chronic acid reflux. Pricey medication, over $6 a day. We switched to pantoprazole, therapeutically equivalent, less than $1 a day. Over $2,000 savings with this one medication in this one patient. And then my last example here is the biggest one. This person was on Nasonex, which is a brand name allergy medicine. It's a steroid nose spray. It's a 102. Usually those nose spray inhalers will last about a month, so it's about $122 a month. Switch to fluticasone, which is the generic equivalent, $38 a month. $1,000 savings on that one, and then they switched also from Diavan, which is a blood pressure medicine, to the lisinopril. Almost $1,500 savings on that. Total savings almost $2,500 for that one patient. So as you can tell, it doesn't take a whole lot of patients to make this very cost effective. And so how do the patients like it? Well, sometimes patients are squidgy about this sort of stuff. They think the health plan's calling them just to save money and all that. Often they don't take it very well. But our patients I asked our pharmacists who call these folks, and they basically say everybody loves it. They're usually, the comments are to the tune of, I'm glad you're concerned with my medications and health. Every penny saved counts. I wish I knew about this sooner. While you're at it, can you switch all my other medicines and plus my husband's medicines and all that? So patients typically really appreciate that we're calling them and telling them about this stuff. And here are some of the things I think that we find are the real keys to a positive patient response. One, I really do think it's important that when they call, they can say, well, Dr. Carter already approved this. Whoever your doctor is, they gave us permission to call you about this. Another thing is, just getting people to answer the phone is a big deal. And we find that if the pharmacy is calling from Kelsey-Seybold Clinic, so the pharmacist is, what shows up on your caller ID is Kelsey-Seybold, which is your doctor's practice, patients will often answer the phone for their doctor before they might answer the phone for other folks, for the health plan or a pharmacy benefits manager or a third-party disease management program. So we think we're able to get folks to take our calls maybe more than some of our colleagues. Another thing is that the pharmacist has immediate access to the patient's medical record. This is another thing that I think is just absolutely essential. Otherwise, you're stuck with this idea that, well, Dr. Carter said it was okay, but really we don't know if you've had any trouble with this before. So what you're going to need to do is go make an appointment to see your doctor and talk about whether you can make this switch. That will kill it, I think. So patients like the idea that I don't have to make a separate office visit. We can do all this in the context of one phone call, gets called in or e-prescribed to my pharmacy, and away we go. And then finally, patients really do appreciate the cost savings. Co-pays for patients and co-insurances, deductibles, all that are going up. Pharmacy's no different. So these patients are typically paying a whole lot of money for this stuff. And if you say, listen, we think it's okay to switch to this, should work just as well, would you like to do it? Typically the response is pretty positive. And I'm assuming most of you are from Houston. If you're not, this guy is known as Mattress Mac, and his catchphrase for as long as I've been here is, we're going to save you money. And I think he's probably one of the few people would actually answer the phone if he called. So I probably owe him money now for using his picture, but Houstonians love it. I mean, I think everybody does. We're going to save you money, and it's not going to hurt, and you're going to do fine. So people really respond to it pretty well. So how the overall numbers changed. This is our generic fill rate, and the RxQI program is not the only thing that's made this change, but is part of it, probably a significant part. 2007, we've always kind of led the community, I think, in this. In 2007, we were about 66% generic filled. By 2011, we were up to 81%. And the RxQI program really started getting really rolling in about 2009, 2010. And even though this increase in generic fill rate may not be due, most of these patients may not have been contacted by the RxQI program. One thing I will say is that doctors, now that we're seeing this stuff every month, and now that it's been kind of put in our face that look how much this costs, look how much we can save, that's a signal to the doctors that the next time I want to write Nexium or Actonel or one of these high-priced brand name drugs, I think our doctors have definitely gotten the message that why not just prescribe the cost-effective stuff to begin with. So it's had a bigger effect, I think, than just the individual patients that we've switched. It's also been a good signal to the doctors as a whole to pay more attention to this, and I think they're doing a pretty good job with that. Compared to the community, we have some data about us compared to our colleagues in the community. This is a large employer group that part of their employees are covered by Kelsey Care, which means they come to us and are eligible for the RxQI program. The rest are typically taken care of by non-Kelsey-Seybold physicians, and it's a big employer, large network health plan. So I think this is reasonably reflective of the commercial insured community. We're at 81% generic fill. Our colleagues are about 74% generic fill. And remember, again, I'm supposed to know this stuff, and it still kind of blew my mind that it's $1,000 per patient per year per drug. So if you're talking tens of thousands of patients, that difference in generic fill rate is just a whole lot of money that's being left on the table. Talking about our program in particular, this again is the same large employer group. This is the number of actual patients that have been switched in a year's time. And again, the cost savings for each one, this is split into patient savings and plan savings. Plan tends to save a little bit more than the patient, but the patients save a lot. It looks like nasal steroids, the patient actually saves more. But again, you're seeing not quite 500 patients switched and over $1 million over $500,000 in savings. So again, that one medicine is about $1,000 a year difference in cost when you get them to switch. That's for that one employer. Our overall results, it's almost 1,000 patients that were switched in 2011. Total savings, a little over $1 million. And the other thing I'd like to point out here is the physician response rate. The doctors really have accepted this quite well. Once we kind of got used to, looking this stuff up and realized how easy it was to use that website interface, doctors, do it in 5 minutes. They can do all their switches or approve all their switches. So the response rate, 98% of the doctors who have patients who might be switched have responded. And of all the potential drug switches, they are approving over 80% of them. So our doctors are well on board with realizing that the vast majority of patients on these high-priced brand name drugs can easily be switched. And as long as we don't have to do the legwork, we're perfectly happy to approve it. So again, over $1 million of savings in 1 year. And so let's see, I have a few final slides here, then we'll open up for questions. Final comments, switching to generic equivalent medications saves a whole lot of money without adversely affecting quality if you do it right. So the things I talked about that contributed to our acceptance by physicians and patients is really important, but if you have the system set up like this, it really does, it makes everybody happy. Lowering the patient out-of-pocket medication cost tends to increase compliance and satisfaction. I have plenty of patients who get put on medications that are pricey and expensive, and probably one of the first things they do is say, Dr. Carr, I can't afford this stuff, and I wind up switching them. But patients that are out there spending a lot of out-of-pocket money for this stuff, somebody calls them up and says, hey, would you like to switch to something that's going to be, half or less price out-of-pocket, probably much less than that. They're thrilled about it. Gaining physician acceptance is the key. As I said, we're lucky, I think, to have doctors that are willing to do this without much squawking, but doctors can easily sabotage this effort if they feel like they're being forced to do it or some outside agency is beating them over the head about this stuff. So getting the doctors to accept the idea that this is good and go along with it is really also very key. Those were final comments. These are final comments. A few more final comments. I do think that how do you get doctors to buy into this stuff? I really do think the practice structure makes a big difference. My colleagues that are in solo practice, small group practice, I don't think they're quite as tuned in to working on evidence-based, cost-effective medicine. They certainly complain plenty about health plans and everybody else telling them what to do, but in our system, they're all employed. I mean, we all work for the same organization. We have physician leadership, so each of our doctors has a department chief. I'm the department chief for the family medicine department, and I basically hired almost all the doctors that are in my department. So if I call them, they do answer it typically, and if we educate our doctors and say why we want to do this and how this is good for the patients and good for Kelsey-Seybold, they're very, very willing to buy into it. So that the multi-specialty group practice really helps a lot of that stuff going on. If you've heard about accountable care organizations being bandied about, this is what it is. In my mind, the prototype for the ACO is a multi-specialty group practice, particularly ones paid by capitation. And this is one of the ways that sort of physician organization really works well and makes a lot of difference. Management infrastructure is every bit as important, so that the type of IT support it took for us to get these claims files in, to be able to analyze them, split them out into individual doctors, set up that website. I mean, that was a lot of work. The doctors don't know how to do that. Nurses don't either, and most of my colleagues in the community probably couldn't come up with that. Also, the intrinsic pharmacy staff. Nobody has that. And that's a really good advantage for our doctors here in our group. We have this group of very knowledgeable people, know more about drugs than we do, who can sit there and talk to our patients about this and spend the time to get them to buy into it and make these changes. It's just, you couldn't do that I couldn't do that if I was in practice on my own. So unless you've got that kind of support, the burden of this sort of program would probably fall pretty much on the doctors and nurses, who already typically are overworked and don't have the time to do it. So even if they wanted to, I don't think it would happen. And this is my last slide, final comments. I do think that connection that we have between our group practice and these two health plans, the Kelsey-Care powered by Cigna and Kelsey-Care Advantage, really allows for the first thing which we needed was the claims data that was necessary to get this whole thing started. So that sort of close connection and the willingness on the part of the health plans to listen to this crazy idea and say, yeah, that's a great idea, we will help you with that, that makes a whole lot of difference. And again, most doctors in solo practice, small group practice, don't have that type of a connection, and it really does make it much easier for us as a physician group to do these sort of innovative things, which again hopefully is a win-win-win for everybody: higher quality, lower cost, higher patient satisfaction. So with that, I will stop, and I think we can open it up for questions now. You're assuming I can read this. I'm reading it off of a computer screen. What can be done to address cost savings related to Medicaid and the rebates the state receives by allowing patients to continue receiving name brand prescription? I am not sure I can answer that question, to be honest with you. I think with Medicaid, I know that they are trying to do more in the way of disease management with getting Medicaid patients into HMOs. Again, the sort of thing we're talking about here, I think, pretty much requires probably an employed physician group, and honestly I can't tell you if somebody like Harris County Hospital District, they could probably do something like this if they wanted to, but I don't claim to be an expert as far as the rebates that go back and forth with the Medicaid patients, but I would think this sort of thing could be done if you had the same sort of health plan and physician practice structure that we have. Next one is, how do specialty drugs impact future cost increases? Any best practices to address this? That's a great question, and the stuff I was talking about here today are the not. I mean, they're expensive enough, but they're not uber expensive like all the new specialty drugs coming out. There's a lot more outpatient pills being handed out by doctors like me than there are specialty drugs, but you're probably aware the specialty drugs now we're getting into very high priced stuff, the biologicals and things like that, which can easily be tens of thousands of dollars per month, over $100,000 per year. We are addressing that at Kelsey-Seybold, not really through the RxQI program like this. The specialty drugs that are now out and are coming out typically are prescribed by our subspecialists, the rheumatologists, endocrinologists, the oncologists, folks like that. The departments, we've asked the department chiefs for each one of those specialties that has drugs like this coming out to meet with their physicians, come up with guidelines about who are the patients that need to be on this and who are the patients that probably should be on something else or try something else sooner. So, and those sort of guidelines are available. A lot of doctors don't necessarily use them, but we do think in our practice situation we can get a good consensus on how to take care of someone with bad rheumatoid arthritis or someone with HIV disease, someone with certain types of tumors, those sort of things, certain dermatologic conditions that are now requiring biologicals. So that's more of a individual patient, individual physician approach. So again, though, the basic rule, which is that the doctors are the best ones to approach this sort of stuff by making sure that when they prescribe a medication, it is they're using the right drug for this patient with the stage of disease they're in. And if they need to be on a biological right away, well, that's what we'll do. If it's something where a non-biological or a lower cost medication is the standard of care, and that's what the national organizations recommend starting with, we do think we have the ability to make sure that our doctors are following that sort of protocol. So we are looking at that very closely. We try to scan what's coming up soon. Again, the pharmacists I talked to you about that are working on these individual medication management programs, they are very valuable in letting us know, well, these drugs are about to be approved, this is what they're going to cost, we need to get working on making sure they're being used appropriately. So all we're trying to do is make sure that those high-cost medicines are used appropriately, and that's the way we're approaching the specialty drugs. And let's see, is this program only implemented for capitated models like Kelsey-Care? Right now, yeah, that's the Kelsey-Care powered by Cigna and Kelsey-Care Advantage are the ones that we are doing this program on. With our capitated populations, actually, those are the folks that we have the most sway over. Honestly, they come to us for all their needs, and that helps us a lot to control these costs. So right now, those are the only plans that we do this for. And let's see, does this RX initiative just happen automatically? Are any employer approvals or action needed? We just do this automatically. This is what we do as a medical clinic. This is, in my mind, between us and the patients, and so the employer doesn't really have to do anything extra or special. It's just this is one of the things we offer just as a matter of course as part of coming to Kelsey-Seybold.
What about step therapy? How does this work with step therapy?
Okay, Ann asked how does this work with step therapy? Step therapy refers to the idea that for certain high-cost drugs, in order for a high-cost drug to be approved, the patient will have had to been tried and failed on a lower-cost medication. So actually, this doesn't get involved with step therapy because we're going the opposite direction. So in step therapy would come into play if I had someone on lisinopril and I wanted to switch them to an ARB like Diovan, maybe because they had a bad reaction to lisinopril. Often in that case, I have to submit paperwork that says, well, they tried the lisinopril and they coughed or whatever and they couldn't tolerate it. And it's kind of a hassle, to be honest with you, but I would eventually get it approved and be able to move them up. These are patients that are already on the higher cost medicine, and so honestly, by switching to the lower cost, to the generic, one advantage to the doctors is that if they are on a plan or a drug benefit plan where they had to do step therapy before, this is one less patient I have to fill out paperwork on. So the doctors typically know that, well, if I can get this patient on the generic, I know the health plan is never going to bug me about it again, so it's actually an advantage for us to do it that way. All right. I think I beat you all in the submission, so thanks for signing in.
Thank you, Dr. Carter, and thanks to all of you for attending today's webinar. If you would take a few moments to answer the survey about our presentation, we would really value your feedback. We hope that you can join us on September 20th and that you'll save the date, September 20th at 12:30. We'll have our next webinar at that time, delivered by Dr. Tony Lynn, who is the chief of our hospitalist program, and he will talk with you about the inner workings of a successful hospitalist program, how it helps patients and how it helps control costs. We'll send out more information about that seminar to you soon, but if you want to mark the date, September 20th at 12:30 on your calendar, that would be great too. Thank you all very much.